Good evening, respective faculty and my dear colleagues. Today I'm presenting a case of 53-year-old male who is a graduate and has done BCom and is working in a government office, resident of Palam, New Delhi. The patient is a case of chronic kidney disease on maintenance dialysis, that is peritoneal dialysis, now presented with chief complaints of decreased outflow from the PD catheter for 2 days and decreased appetite for 1 day. History of present illness. So I would like to date my history back to around 22 years, that is in 2000, when patient had pain in the right great toe joint, which was severe, associated with swelling and the redness of the joint, and the pain increased on movement of the joint. So there was no history of any trauma or any discharge from any lesion over there at that time. For this, it was not relieved by oral medication. So the patient was admitted for around 2 to 3 days and was given IV pain relieving medications and was advised tablet febuxostat, as he was told that his uric acid was increased, and was discharged after 2 to 3 days. Then patient continued to take the medication and did not have the same episode later and was not taking any pain relieving medications later on. Then after around 8 years, in 2008, the patient had used to have a headache which was diffuse, used to remain throughout the day, and it was mild in intensity, non-radiating. It was not associated with any complaints of fever, nausea, vomiting, or any ear or nasal discharge, or decreased vision, or any weakness of any side of the body. So he consulted the nearby physician and he was told to have increased BP. With, the upper one he remembered was around 150 to 160 millimeter of mercury and was advised BP lowering medications. He took the medications for a few days and then left the BP medications and started Ayurvedic medications, which he took for 1 month and then did not take. At that time, there was no associated history of any decreased urine output or swelling of feet or red or cola colored urine, any episodes of cough or breathlessness, no history of repeated episodes of increased BP or sweating, or long-term intake of any indigenous medications. Then he was doing for fine for around 11 years. In the year of 2019, he started complaining of decreased appetite, which was associated with low back pain. The pain was dull, aching, non-radiating, and slightly increased with the movement and relieved with the rest. He also complained of altered taste sensation at that time. There was no history of fever, hematuria, or lower urinary tract symptoms. There was no history of pain abdomen or loose stools at that time. There was no history of breathlessness, cough, or swelling of feet. And there was no history of decreased urine output. There was history of increased frequency of urination at night. He used to void at around 3 times at night. Then he consulted the nearby physician, and on investigations, he was told to have dysfunction of the kidney functions, and creatinine he remember was around 3.5, and he was also told to have decreased hemoglobin. Ultrasound of abdomen was also done, and he was told that both the kidneys are small and there is a small stone on the right kidney. After that, he was advised multiple medicines, and he was compliant to that medications and used to visit as per advice every 1 to 2 months. Then after around 1.5 years, his creatinine slowly progressed from 3.5 to 7. And at this time, he also had complaints of increased fatigability, decreased appetite, and decrease urine output to around 500 ml per day. And he was advised to renal replacement therapy. Multiple options were advised, and he opted for the peritoneal dialysis, which he says that he was advised to that a catheter will be put in the abdomen, and the catheter was inserted, and fluid exchanges were started after around 14 days, which he used to do with the help of a machine at night time, and the caregiver was his daughter. He used to do it for around 10 hours initially, with 5-liter bag, and the percentage also he remembers it was 1.5% and 2.5%. And daily extra fluid removal was around 700 to 800 ml per day. Then he was doing fine for after starting PD for around 6 months, when he had fever, which was around 101 degree Fahrenheit, continuous, associated with chills, and was not relieving with the oral medications. Also, at that time, he complained of pain abdomen, which was diffuse, and there was no aggravating or relieving factors. And also there was a cloudy outflow from the PD catheter, which he says it was like a rice water. And there was no redness of the fluid. There was no history of any redness or discharge from the exit side. There was no history of loose stools or any constipation at that time. No history of cough, breathlessness, or burning maturation. There is no history of any invasive procedures done at that time, and no history of PET in the family. Then at that time, the caregiver was changed from daughter to the wife, as it was a COVID time and his daughter is nurse. So he had to do night duty. So the caregiver changed to the wife. At the same time, he also says that the urine output also decreased to around 300 ml per day. Then he consulted his training man from the Mitra company, what he says, and he was told that he might have got infection in the PD fluid. So he was advised to send a sample, which he sent, and his intraperitoneal antibiotic was given for 5 days. The name of the antibiotics he did not remember. But after around 5 days also, the pain abdomen and the rice colored fluid did not improve. So he was advised, and after admission, he was given IV drugs, and he was advised for the removal of the catheter. During that time, the PD catheter was removed, and catheter was inserted on the right side of the neck, and hemodialysis was given, which was given twice a week. And the patient was discharged with the catheter in situ. Then he took the IV medications for around 14 days, and the hemodialysis was continued for around 1.5 months. After around 1 month, the PD catheter was reinserted, and advised peritoneal dialysis, but this time the hours were increased from 10 hours to 12 hours. And the dialysis catheter from the right side of the neck was removed. Then he continued the peritoneal dialysis with the help of machine with 1.5% and 2.5% bags of 5 liter each for 12 hours. And the caregiver was daughter. The total output from the catheter was around 1100 to 1200 ml in a day, the extra output. And the urine output was around 200 ml. And he was also advised creation of fistula at this time. After few months, he got fistula creation on the left side of the arm. And then the patient was doing fine, and for 1.5 years. and then presented complaints of decreased flow from the catheter uh, for 2 days. According to the patient, there was no problem in inflow, but after the first well only, there was no outflow from the catheter, and he could not do the further dialysis, and the fluid was removed in the morning manually. During which he used to move from side to side, and there was a difficulty in draining, but the fluid was drained in the morning, which was around 1500 ml on both the days. And after 1 to 2 days, he felt decreased appetite and generalized weakness. At this time, there was no history of pain, abdomen, fever, or any cloudy color outflow. There was a history of constipation is present. So he came to the hospital with the above complaints, and he was advised admission, and on kidney, and he was told that his creatinine has increased to 18. And this time again, the hemodialysis was given, which was done through the fistula, and 2 sessions of the dialysis were given. And at the same time, the patient was given enema for the constipation, and the outflow from the catheter, PD catheter, improved.
Yeah. So can you just sum up? Can you just sum up what you've told us before he reached the stage of dialysis?
Yes, sir. He is a 53-year-old male with complaints of pain right in the right great toe, most likely gouty arthritis 22-year back, for which he used to take regular medication, that is febuxostat. And then after around 8 years, he had hypertension. He was diagnosed to have hypertension, for which he did not take regular medication. He was doing fine for around till 2019, that is 3 years back, when he had decreased appetite and low backache, and he was diagnosed to have a chronic kidney disease. He was told to have small kidneys and the stone on one side of the kidney.
Okay.
After which,
yeah, let's stop at that. So yes, when he developed chronic kidney disease, you're saying he developed chronic kidney disease historically. What do you think led to his chronic kidney disease?
So most likely it is a chronic interstitial nephritis.
Yeah. Do you think your patient had a metabolic syndrome?
So metabolic, so in
what
the
is
history,
the definition of a metabolic syndrome?
So 3 out of the 5 criteria should be fulfilled. One is the hypertension, or the patient is taking medication. The other is the diabetes, fasting blood sugar more than 110, or history of any medications for the same. Then increase in triglyceride more than 150 milligram per deciliter, and decrease in HDL less than 40 in males and less than 50 in females, and obesity.
Yeah. So do you think your patient was obese?
Sir, as per the, no, sir.
What was the BMI of your patient?
So currently the BMI is 23.6.
So not now. Earlier, was he obese earlier? See, your patient had hypertension. Your patient had hypertension. Historically, he's got gout. There is a history of Ayurvedic drug use in this patient, and then followed by azotemic symptoms. Suppose I tell you this is a hypertensive chronic kidney disease and not a chronic interstitial nephritis. What do you have against it?
So hypertensive kidney disease, so actually he was diagnosed to have hypertension at around the age of like 22 years back.
Yeah, so he was a hypertension in young, no?
Yes, sir. It was at the age of around 38 years.
Okay. So suppose I tell you it is hypertension related chronic kidney disease.
So usually the hypertensive related kidney disease occurs after around 15 to 20 years of uncontrolled hypertension. And it occurs in around 5 to 7% of the patients with BP of more than 160, systolic BP of more than 160.
And associated with?
Okay, associated with other features of metabolic syndrome.
No, with other target organ involvement. When you come in the examination, you will tell us what is the other target organ which is involved. Now, why do you say it is chronic interstitial nephritis?
Like it started with the complaints of gouty arthritis, increased uric acid levels, and then later there is also history of stone in the kidney. And
so how does gout affect the kidney, or how does hyperuricemia affect the kidney?
There are multiple pathways. One is that the uric acid can deposit in the interstitium, which was thought to be earlier to be due to the interstitial deposition of the uric acids. And then others are that it can cause endothelial damage and affect the mitochondria and cause the endothelial damage. And the other is that it can activate the RAS and cause glomerular.
What are the kidney syndromes associated with hyperuricemia?
Okay, so
I'm not asking about pathophysiology. Clinically, does hyperuricemia cause interstitial nephritis?
Chronic interstitial nephritis it causes. It is a cause of chronic CI, chronic interstitial nephritis.
It is an association. It is not a causation. Why is there an association between CIN and hyperuricemia?
So due to these multiple pathways, it can affect the kidneys, like vascular damage.
नहीं आप समझे नहीं. Chronic interstitial nephritis, you get hyperuricemia. But I'm saying hyperuricemia does not cause interstitial nephritis. So how does chronic interstitial nephritis cause hyperuricemia? Why I'm asking you is probably your patient had a chronic kidney disease when it led to gout in him.
Okay, sir. So like tubulopathies can cause increased uric acid levels because the uric acid reabsorption is compromised and the uric acid levels may increase.
So in chronic interstitial nephritis, you may have impaired excretion of uric acid. I'm not trying to go into the mechanism where it is first absorbed, then secreted, again absorbed, and finally excreted. But in CIN, you can have hyperuricemia. Okay. How else does hyperuricemia cause kidney disease?
How hyperuricemia causes kidney disease? So one is the vascular damage due to mitochondrial and endothelial.
No, don't go into the cell. Tell me clinically.
It can cause renal stones and
one is uric acid stones. Okay, then
uric acid crystal deposition in the interstitium.
Yeah, it can be deposited in the tubules and cause obstructive uropathy, intrarenal obstruction due to uric acid crystals. Okay, why do you think your patient had a low backache?
So maybe that is a part of mineral bone disease, because at that time the chronic kidney disease was also diagnosed. So generalized body aches and low backache may be a part of CIN.
Okay, so your patient had CIN, CKD, and he came on to a dialysis program. I'm sorry, I missed after that. My thing went off. I'd request Dr. Vinant to take over from there.
Yeah, so we'll just go back to the fact that in the history that you've told us that there was a creatinine of 3.5, and then within 1.5 years, the creatinine shot to 7. So do you think that, does it fall in line with the diagnosis that you've made and given to Dr. Narula sir about chronic interstitial nephritis? Do you think chronic interstitial nephritis behaves like this, in which the creatinine rises from 3.5, goes to 7 in just 1.5 years?
So usually, like the earlier part was slow progression over 22 years from increased uric acid to development of the kidney disease when he came to know. It took around 20 years. That part fits in the later when the creatinine was already 3.5 and it jumped to 7. The major GFR loss, like at 3.5, the GFR was already less than 20. So
Yeah. So if
be,
I say at that time that you said that he has low backache at that time, and then he was detected to have low hemoglobin, that's what you told us, right?
yes.
And then you say the creatinine from 3.5 goes to 7 all of a sudden. Then what comes in your mind at that time?
So maybe if the patient could have taken a pain relieving medications in the form of NSAIDs or
Anything else that comes in your mind? Low hemoglobin, low backache, and then suddenly the creatinine.
add in older age, we can think of multiple myeloma in such patients, low backache with the decreased hemoglobin.
So you think your patient has some kind of a plasma cell disorder?
So, but at that time, the hemoglobin, when as the patient told that he was given oral medications and the hemoglobin he was maintaining. He never required any blood transfusion or further decrease in hemoglobin.
Yeah. So the no need for blood transfusion and improvement with medication will actually go against the fact that you're thinking of a plasma cell disorder. After that, you said that he opted for peritoneal dialysis and he was started on peritoneal dialysis. So what is the most important thing when you have to put a patient on peritoneal dialysis?
So the residual urine output should be maintained.
What is it called? Residual
renal function.
renal function. How do you define residual renal function?
So if the urine output of the patient is more than around 200 ml per day, it is considered sufficient.
So why is it 200 ml? It could be 300 ml also.
So it is for the maximum osmolality of the urine to get excreted. The minimum amount of urine which is required is around 200 ml per day.
Yeah, so the minimum amount of urine that is required to excrete solutes is about 200 ml. So what happens if you put a patient of peritoneal dialysis and he doesn't have a residual renal function? How does it change the CAPD or the peritoneal dialysis?
So the requirement, like initially the patient was started on 2 bags APD only for at night. Then the patient requirement will be the more of increased osmolality of the dextrose may be required, and number of dwells needs to be increased, which may lead to early burnout of the patient and the peer.
So you need more dwells, or you need more, you need to increase the number of dwells, or need to increase the timing of dwell if you have poor residual renal function?
So the number and the osmolality we need to increase.
We need to increase both. Okay, yes. So after that, you said that this patient had developed intraperitoneal infection. So that is a peritonitis, right? You said the patient developed peritonitis. And then after 5 days of treatment also, the patient did not improve.
Yes, sir.
And then after that, the catheter was taken out.
Yes, sir.
And then the patient was placed on hemodialysis, and then he was given 14 days of intravenous drugs.
Yes, sir.
So what's the best way to treat patients with peritonitis?
So usually when the patient, we are thinking of peritonitis in a patient, the PD fluid total cell count and the Gramston and the cultures are sent, and then the patient is started on intraperitoneal antibiotics, which empirically both the gram positive and the gram negative coverage is to be given. And then after around 48 to 72 hours, when the cultures arrive, and if the patient is improving, we change the antibiotic according to culture sensitivity. And if the patient is not improving till 5 days, 96 hours, then it is labeled refractory peritonitis, and the PD catheter removal is advised.
Suppose you have somebody whose pain improves, but the effluent does not improve. That is, the cloudiness stays. Then what do you do with such a patient? And your culture is turning out to be negative.
So if the patient is clinically improving, we will look for total leukocyte count also. And if the total leukocyte count is also improving, then we can give the antibiotics for more than 5 days without catheter removal.
Yeah, so the TLC is staying stable. It's not improving, but the pain has gone away of the patient. And it's already 5 days and the patient is culture negative.
We can wait. Symptoms are improving, so clinically the patient is improving.
Yeah,
And
so clinical is what is important. So clinically, if the patient is getting better, you can actually wait. So what are the absolute indications for removal of PD catheter? Absolute indication.
So refractory peritonitis, relapsing peritonitis, then repeat and recurrent peritonitis. And if it is a fungal peritonitis, and
so I asked you a question, what is the absolute indication? What is the absolute indication of removal of catheter? So you have this condition and you have to remove it.
If it is associated with tunnel infection and the fungal peritonitis.
So fungal peritonitis is an absolute, it's absolute indication for removal of catheter. And then after that, he was put on hemodialysis, and then the reinsertion was done after 1 month. So
Yes.
what is generally the trend of reinsertion of catheter? How much time would you want to reinsert another catheter? And how do you decide? Suppose this patient had fungal peritonitis. And how much time would you actually reinsert the catheter?
So if the patient is clinically stable and there is no growth in the culture and the TLC is also less than 100, then we can go for catheter insertion. And after catheter insertion, at least 14 days of antifungal therapy is to be given.
Right. So no growth in which culture?
PD fluid culture.
So this is the PD fluid culture which you had sent before removal of the catheter.
Yes.
So but what is the best way to detect fungus in the PD fluid? The simplest and the best?
Gram stain.
Is the gram stain. Okay. So.
Yeah, okay. I think Dr. Vinant has quizzed you a lot on what you have presented, but I want to take you down to basics. You mentioned something about residual renal function and you mentioned about CAPD, right? Yes. Now, what is the connection between residual renal function, PD, and hemodialysis?
So usually, if the patient has residual renal function is maintained, then patient PD, we can advise the patient to go for peritoneal dialysis, and these patients do well on the peritoneal dialysis.
Why do you want to retain the residual renal function?
So because there are some functions which are done by the kidney, which the dialysis cannot take over, in the form of endocrine functions of the kidney, vitamin D synthesis, EPO synthesis, and then the middle molecule clearance is better with the.
Okay. So how is PD beneficial in these patients?
So there is a decreased exposure to the external things like the tubings we are using in HD and the dialyzer cellulose.
When you take a patient onto CAPD, you are preserving the residual renal function, which gets lost earlier in hemodialysis. That is the advantage, a very big advantage with CAPD. Yes. Okay. Now the next thing that you're coming on to is the infections you spoke about. And you said that something about membrane failure. You mentioned about membrane failure to Dr. Vinant. So how exactly you do the membrane suitability or the PET test in patients on PD?
So usually we look for the transport status of the patient. That is done by the modified PET test. So it is done overnight. We are 8 to 10 hour well is done, and then in the morning the modified PET test is done by 4.25%.
2.5, not 4.25. It's done by the 2% point. Okay. Then.
So the fluid is instilled and the patient has to roll every 2 minutes it is done at around 200 ml per hour. 2 liter fluid is instilled, and we take the samples at.
Have you ever done it yourself?
No,
No. So 2 liter fluid is fine. You have to give it in how much of time?
10 minutes.
10 or 20? 10 minutes?
10
Okay.
minutes in frozen.
Yeah. Then what do you do?
So then at zero time, we have to take, we took out 100 ml of the fluid for samples at the 0 time.
200 ml of fluid.
200
And then
ml.
what do you do?
So of that, 10 ml is discarded and 10 ml is sent for the investigations.
10 ml is taken for the test and the remaining is returned into the peritoneal cavity.
Yes, sir. Rest is.
Yeah. Then what do you
Yes.
do?
So then after 4 hours.
No,
we-
no. You've not yet reached 2 hours. What will you tell the patient after you return it? You'll tell him to walk around.
Okay, sir.
And then at 2 hours, what will you do?
Serum sample is to be taken
Along with?
along with the peritoneal samples again, creatinine
Then
and
what do you,
glucose.
then what do you do?
Then we took the samples at 4 hours.
Only peritoneal fluid sample at 4 hours. And you drain it and see the volume which is coming out. Okay, now why are you doing this?
So because to know the transport status of the membrane, and we can advise the dialysis prescription accordingly.
Yeah, so this is what Dr. Vinant was asking you. More number of bags, frequent higher osmolarity of bags, you can make out by doing the PET test. Now, what do you make out in PET test? Suppose, what are the nomenclatures used?
So one is D by P creatinine we have to look for.
No, you have the high transporters, you have the low transporters.
Yes, high transporters, then high have average, then low average, and the low transporters. Low transporters have D by P creatinine of less than.
So don't go by absolute values because these numbers you will forget. All right. So when you have a low transporter, how many bags? When you have a high transporter, how many bags? How frequent in a high transporter? How frequent in a low transporter?
So in a low transporter, three exchanges per day. We can start with 3 exchange per day, and then
so you keep a longer dwell time.
Longer dwell time and less number of exchanges.
Very good. High transporter?
The more number of exchanges for the shorter time.
So what mode of PD will you select in a high transporter, and what mode of PD you select in a low transporter?
So in high transported, AP, automated peritoneal dialysis is preferred, and in low transported, continuous ambulatory peritoneal dialysis is preferred.
What about day dwells?
So day dwells are usually for the important for fluid removal in APD patients.
And for low transporters, you can keep the peritoneal dry in high transporters. That's the advantage what the PET test will give you. Okay, the second thing you all discussed was about infections. What is the criteria to say that there is peritonitis?
So usually there are 3 things, 2 out of the 3 should be met. The patient's symptoms we have to look for, either abdominal pain, plus minus cloudy effluent, one. Then second is the total leukocyte in the PD fluid should be more than 100. In APD patients, it can be less than 100, but the neutrophils should be more than 50% of the total cells. And then the third is the culture. The culture should be positive.
Okay, so you have, what are the causes for a cloudy effluent other than infections?
Cloudy effluent can be due to cellular causes and non-cellular causes. In the cellular causes, other cells in the form, like if there is bleeding, that can cause. Then if there is increase in monocytes after a dried well, if we are taking out the fluid after a dried well, then it may be cloudy. due to increase in monocytes. Then the increase in eosinophils, like in inflammation, or if it is
Can
then,
lymph cause a cloudy effluent?
yes, sir, that comes in non-cellular causes. Lymph can cause, then drugs in the form of calcium channel blockers can cause the cloudy effluent.
Yeah, good. So when you get a patient with a cloudy effluent, you must look for all these things if he doesn't meet 2 out of the 3 criteria. Now, which are the antibiotics you prefer in your patient?
So for the gram-positive coverage, they have given either first-generation cephalosporins like cefazolin or vancomycin is to be given, and in the gram-negative coverage,
Yeah, I'm listening to you.
third-generation cephalosporin or the aminoglycosides can be used.
Okay, which are the antibiotics you would not like to give intraperitoneally?
In antibiotics, fluoroquinolones, usually we prefer to give orally. And
okay, now, Vinant, would you like to add anything to this?
So we can just proceed, I thought, with the next part of the.
Okay.
so then can I start with my past history?
Yeah, now history is over. Now go on to clinical examination.
Okay. Patient is calm, conscious, cooperating, sitting comfortably on bed, is moderately mild and moderately nourished. The heart rate is 88 per minute, regular, good volume, no specific corrector, and all the peripheral pulses are equally palpable, and vessel wall is not palpable. The blood pressure is 156 by 84 millimeter of mercury in right arm supine position, and 150 by 90 in right arm sitting position. The BP is 150 by 90 in the left arm supine position and 150 by 80, 88 in right leg supine position. The respiratory rate is 16 per minute, thoracoabdominal, and the patient is afebrile to touch. The height is 157 centimeter, weight is 60 kg, and the BMI is 23.6 kg per meter square. Graying of hairs is present, pallor is absent, icterus is absent, there is no cyanosis, and no JVP is not raised. Pedal edema is present bilaterally, and in the skin there is scar mark present on the right side of the neck. Then so there is AV fistula on the left, in the left elbow area. Left BB AV fistula is present. There is a linear scar mark of around 2.5 centimeter in the left proximal forearm. There is no swelling of the arm or the localized swelling, no redness or any discharge. On palpation, the pulsation is regular and the thrill is soft and easily compressible. It is non-tender to touch. And on auscultation, the brew is continuous. And on arm raise test, there is no visible prominence or in the fistula area. And the pulse augmentation test, the fistula becomes prominent. Then in the per abdominal examination, there is no abdomen is distended and all the segments are moving with the respiration. The catheter with the transfer set is tied to the abdomen with the help of a belt, and the exit site, so it was bandaged, so I didn't open it to see. And there is a scar mark which is visible 2 centimeter below and lateral to the midline on the left side, with another scar mark around 8 centimeter from the midline. And on palpation, it is soft, non-tender, and there is no organomegaly. On auscultation, bowel sounds are present, and there is no renal bruit audible. In the chest, it is bilateral, symmetrical. Both sides are moving equally with the respiration, and there is no localized bulge or scar mark or prominent veins. prominent vessels. On palpation, it is non-tender, and on percussion, it is all the areas are resonant. And on auscultation, vesical breathing sounds are heard and there are no added sounds. On the cardiovascular examination, apex beat is not visible on inspection and there is no precordial bulge, scar mark or pulsations. And on palpation, the apex beat is present in the sixth intercostal space, just lateral to the mid-clavicular line. On auscultation, S1 and S2 is here. A2 is comparatively louder to the P2 and there is no S3 or murmur. In the CNS examination, patient is conscious and well oriented to time, place, and person. And there are higher mental functions are normal, and so, there are no any motor deficits. The power is around 4/5 in the lower limbs and 5/5 in the upper limbs. And the reflexes, all the reflexes are present, like elbow reflex, triceps and the biceps, and knee jerk and the ankle jerks are present. On the fundus examination, so grade 2 hypertensive retinopathy is present. Examine.
Yeah, Dr. Vinant, would you?
Yeah, so just can you just summarize the positive findings of your examination right
So one is the
now,
patient's
which is going to correlate and help us make a final diagnosis on this patient.
So BP is on the higher side. BP was 156/94 in the right arm. And then the bilateral pedal edema is present on examination. And then so the scar mark of the previous HD catheter insertion is present on the right side of the neck. And AV fistula is present on the left side of the arm. And in the abdominal, the scar marks of the previous PD catheter insertion are present. And current catheter is inserted. So I didn't open the bandage to see for the exit site, but there was no on palpation, there was no tenderness along the tunnel also on the sides of the tunnel.
So what are the other findings that you found, which was tell us about some end organ?
On the cardiovascular examination, sir, for the other end organ damage due to hypertension, the apex beat is present in the sixth intercostal space, just lateral to the mid-clavicular line, and A2 is comparatively loud than P2. And fundus examination showed retinopathy.
Okay. You said that this patient has a fistula in the left upper limb, right?
Yes, sir.
Okay. What sort of a fistula does he have?
So it was on the medial side, so it brachiobasilar.
It's a brachiobasilic fistula.
Yes.
So why does somebody have to have a brachiobasilic fistula for the first time that they have to have a fistula?
So he was told that the veins are thin in his at his wrist on both the sides. So the fistula was made.
So when a brachiobasilic fistula is made, what is the most important thing that you need to know about the patient before the brachiobasilic fistula is actually ordered for a patient?
The cardiac status of the patient, because the flow is high, it will be high outflow fistula. So we have to look for the cardiac status. Ejection fraction is important.
Right. So this patient surprisingly has no positive findings in the central nervous system. What are the positive findings that you would expect a patient of this sort who's been having chronic kidney disease since now approximately 20 years now? And
Yes.
he's been put on dialysis. So what do you think should be there in the central nervous system?
These patients can have axonal neuropathy. So
I'm surprised that there are no signs of any peripheral neuropathy. In fact, I think you checked for autonomic neuropathy also.
So BP I looked for, there was no, I checked in sitting and the lying down position.
So what is the first sign of autonomic neuropathy in patients with CKD?
Postural drop of BP.
Before that, the first sign. So the first sign of autonomic neuropathy is basically an erectile dysfunction in these patients. So that's always the first thing. So, so should we ask for the final diagnosis, or you want to add something, sir?
Yeah, no, I want to get her thoughts cleared. You know, when you do a systemic examination in a patient of chronic kidney disease on dialysis, like Dr. Vinant said, you must know what you're looking for. For example, if you're looking for peripheral neuropathy, you should be clear what all will you see. You should look for the sensory system, you should look for the motor system, you should look for the reflexes. Very important, you never mentioned anything about proximal myopathy. This is the patient who long-standing chronic kidney disease had a low backache. So you never mentioned about the myopathy. Can he get up from the squatting posture or not? So that
Yes,
is
sir.
very important. Yeah, so this is something which has to be told to the examiner, that you know proximal myopathy can occur in your patients and you've looked for it. When you go to examination of the cardiovascular system, you mentioned about apex, outside the mid-clavicular line, 6 space. But what are you looking for when the patient is inadequately dialyzed? We know he's a hypertensive, we know he's got LBH, but what are you looking for on the auscultation of the heart? You should specifically
The
mention.
one is the pericardial rub we have to look for.
Yeah,
Then
so that is what should be specifically mentioned, that there was no pericardial rub. When you examine the respiratory system, there's no point in saying bronchovesicular breath sounds, this is not there, that is not there. The examiner gets, tired listening to it. What are you looking for in the respiratory system?
so basically one is the crepitations, like he was not dialyzed properly for the
Yeah,
2 days. If
crepitation
there
is
is
a
any
very old term. You are looking for crackles.
crackles.
No? So you're looking for crackles in the lung, you're looking for a pericardial rub, you're looking for proximal myopathy. In the history, you're trying to elicit pin and needle sensation in the lower limbs. This is what Dr. Vinant was saying, that you must know what you're looking for. Otherwise, you'll just repeat Hutchison Hunter, and in the end, everybody will forget what you started from. All right. So now, can you sum up in your examination? Does he have any complications of chronic kidney disease in the various systems that you examined?
So one is that he's has increased BP and the pedal
So
edema is
that
also
is
present.
not a complication of chronic kidney disease.
Okay, sir.
No? So what are the complications look for? You never mentioned about skin pigmentation. Did you mention anything about pigmentation? No, you did not. So you must know what to present to your examiner. So first you know what are the complications which occur and you present that these were absent and other examinations were within normal limits. So examiner knows you know what you're looking for. Yeah, now you can carry on.
Should I tell the diagnosis, sir?
Yeah, that's what he asked you, diagnosis.
So the patient is chronic kidney disease, stage 5 on maintenance dialysis on APD. The basic disease being chronic interstitial nephritis with the residual urine output of around 200 ml with hypertension and gout, and currently on APD with 2 bags and with his episode of peritonitis 1.5 year back, currently admitted with outflow PD catheter outflow problem, which is most likely due to constipation.
Okay, so when you have an outflow problem, what all comes into your mind?
The most common cause is constipation, sir. Then if it is occurring early after the catheter insertion, then the kinking of the any segment of the catheter or the tubing is to be seen, and then the catheter tip is to be looked for, and later on it can be blockage due to the fibrin.
So what are you looking for in the catheter tip?
So the position of the catheter tip,
So it's
mostly
known as migration of the catheter.
migration of the
You
catheter.
are putting it into, you told me you have put percutaneously. So when you put it percutaneously, you're going into the pelvic fossa, isn't it?
Yes.
And then it turns and goes up. It migrates up. So
Yes.
one is migration. Okay. So you mentioned migration, you mentioned fibrin, you mentioned constipation, kinks in the catheter. Then
So omental wrapping can occur.
very good. You can have
Later.
omental wrapping for that. So how do you diagnose? What is the cause?
Usually, first we look for the X-ray pelvis to look for the migration of the catheter tip, and if we can also see if the bowel is too loaded or there is any constipation, and if we found that there is migration of the tip and the patient has constipation, then the laxatives or the enema is given, and if the tip migration is not there, and we can also look for the kink in the catheter. Uh, so then
Is there any role for injecting a radio contrast in the catheter? What if we inject a dye in the catheter?
to check for the okay.
To check for patency, to check for the omental wraps? I think you've gone off the screen.
Sorry, sir.
Yeah, no, you went off the screen. Somebody else came in.
Okay.
Okay. So these are the causes for non-flow in the catheter, that there is no returning effluent in the catheter. Dr. Vinant, would you like to take anything else?
Yes. So now, how are you going to assess whether your patient is doing well on the sort of dialysis modality that you prescribe to this patient? How will you assess? And how will you manage if there's a problem?
Mostly in the PD patients, we look for clinical status of the patient. If in the history the patient has no uremic symptoms in the form of decreased appetite or nausea, vomiting, or decreasing weight, and then we look for the weight that the patient is maintaining weight. There is not on continuous loss of weight should not be there.
So what is
And
that weight called? What is that weight called?
we call it dry weight, but in PD,
For PD, you can't call it dry weight.
no, sir.
Okay. So what do you call that weight then? There has to be some weight which you have to have on a peritoneal dialysis patient, which will tell you that this is the right weight. Yeah, so it's called the dry weight only. But how do you assess dry weight in a peritoneal dialysis patient?
Then when there is no PD fluid in the abdomen, we still look for the weight after, like, if the patient is on APD, after the fluid removal in the morning, we can assess the weight.
So if the patient is on PD and you take them off the CAPD fluid, how do you assess the dry weight? How do you assess a dry weight in a hemodialysis patient?
So one is clinically, like we normally do the weight by the weighing machine, or otherwise the bioimpedance other techniques can be used.
You don't have bioimpedance, you don't have the technology of checking the dry weight. Then how do you check for dry weight in a hemodialysis patient?
So the weight at which the patient has no features of either increased hypertension, edema, or neither the hypotension during the dialysis.
Okay, so it's the lowest possible weight that you can get with normotension in the patient on hemodialysis. So then what will you do in a peritoneal dialysis patient to assess the dry weight? It's important to know the dry weight in a peritoneal dialysis patient. Why is it important?
Then only because these patients can gain weight due to because there is increased glucose and there is increased absorption. These patients are at risk of obesity, dyslipidemia, and
yes, that's obviously we know that. But what is the importance of dry weight per se for a patient who's on peritoneal dialysis? Does it have to do anything to do with the prescription, with your testing, with your adequacy? Does the dry weight tell you anything at all?
So, so if the weight, we have to look whether the weight is due to it is actual due to the dry weight is increasing, or the weight is due to inadequate dialysis, the patient is retaining fluid.
Right. So dry weight is important even in peritoneal dialysis patients for only one reason, is for the nutritional aspect. Because most of these patients will lose a lot of protein. So you have to know whether the dry weight is adequate or not. And the method of measurement of dry weight, even in patients with peritoneal dialysis, is almost the same as with hemodialysis. You have to assess for a state in which they're in a state of normotension and do not have any features of volume overload. That's the most important thing. And the second is, when you do a PET test, the most important thing before you do a PET test is to ensure that your patient is either adequately hydrated or adequately unhydrated. So that means has to be on dry weight. So that's the best time that you will get the proper peritoneal status with the PET test. That's the importance of the dry weight. So now you said that first you're going to look at the patient, whether he's achieved his dry weight, whether he's happy with himself. What else will you see?
Then the nutritional parameters, the muscle mass, we can.
What else?
So then in the serum, we look for serum albumin, total.
I think I would look at the hemoglobin first. I think that's most important.
Hemoglobin, anemia, yes, sir.
Yes, I would try to see, because that's the simplest test to do. Just look for the hemoglobin, whether it's adequate. What else will you see?
So, and hemoglobin, and then serum albumin, and then the electrolytes, bicarbonate, and the serum phosphorus also we will look for the adequacy of the dialysis. And for the like patient is not having malnutrition, for that we'll look for the serum cholesterol, and also it should be more than 100 total cholesterol.
How do you calculate the KT by V of a patient who's on APD?
So,
this patient is on APD right now.
Yes, sir. So
how
we'll
will you
collect the total outflow, the total fluid volume we have to look for, and then the urea in that fluid is to be taken, and urea levels, and then the urea levels of the patient, serum urea. Just a second, sir.
Now, is there any difference in calculating method of calculating KT by V in patients who are on CAPD versus who are on APD? Any difference? What is the one most important difference between patients who are on cyclical therapy versus patients who are on, just nocturnal therapy?
In terms of KT by V?
Yeah, in terms of KT by V.
So the patient who is on, yes, sir, the patient who is on continuous dialysis, the serum sample can be taken during any time of the dialysis. And in APD patients, we usually take it in the afternoon.
Right. So is there a difference between taking serum sample anytime and taking it in the afternoon when it comes to measurement of KT by V? Is the goal of KT by V same when you're talking about patients with CAPD and patients with APD?
Yes, sir.
So how do you assess a patient? Suppose this patient is on APD right now. How will you program his APD? For example, I say that this patient has a creatinine of 12. He has a hemoglobin of 9. He has an albumin of 2.4.
Yes, sir.
And he has a phosphorus of 8. What prescription of, how will you prescribe? And he has a residual renal function of, he has residual urine output for about 300 ml. And he was on CAPD before, and his cumulative ultrafiltration was 600 ml with the 3 bags of 2.36%. Now you want to convert this patient into APD. So how will you program the APD?
So, so like this patient is already doing 3.36%, 3 bags. Then when we are doing it at the night time, we can advise the patient to start with the night as well as with the day 12.
Are you satisfied with the information that I've given you, or you want more information about the patient before you give the prescription for APD?
So the BP of the patient.
Normal BP. So I'll summarize. He has hyperphosphatemia, he has anemia, and he has normal blood pressure, but his ultrafiltration is not as per his body weight, and his residual urine output is roundabout adequate.
So like this patient has low UF and the solute clearance is also not good. So as if he is not properly dialyzed. So the patient, this patient may be a the membrane is not functioning properly. So we
So
can
what
go
transport status do you think this patient is?
slow transporter. So
Low transport. So now if I want you to put this patient on APD now, what prescription and how many cycles of APD would you program for this patient, and what bags will you use and duration? And would you also like to combine this patient of APD with something else, or just keep him on APD?
So we can use in this patient APD with the day 12, and the day 12 we can use of icodextrin.
Icodextrin.
Yes, sir.
No, but how will you program the APD? How many cycles?
So the APD.
How many cycles of APD do you give for a 10-liter bag? For example, you have 5 liters. So
usually 5 cycles.
So generally you have 5 cycles. So would you like
Yes.
to have more cycles? Would you like to have less cycles?
We will decrease the number of cycles.
So you want the peritoneal fluid to stay inside the peritoneal cavity for a little longer time with every
Yes.
cycle. Okay. So can you change the volume also of each cycle in APD?
Yes, sir, we can change the volume also.
You can change the volume. Okay. So here you will try to increase the volume and increase the dwell
Time. Yes.
dwell time. Okay. And you'd also want to add a daytime bag. And
Yes.
you want to choose icodextrin for that.
Yes, sir.
Why do you want to choose icodextrin for that?
So because he is a slow transporter, so the icodextrin goes for both. So better for the better UF and.
And suppose you have to use icodextrin, then can you use the APD machine for the icodextrin, or do you have to do a separate exchange for that?
So icodextrin is usually for a longer dwell. So
Right.
we will put it
So
during the.
Can you use the APD machine for icodextrin, or do you want to do a separate exchange altogether?
Okay, so.
So you can have the last fill using the APD machine itself with icodextrin. So you don't have to make too many connections. You don't have to disconnect and then reconnect again with a different apparatus altogether. Sir?
Yeah, no, you carry on. I was enjoying your quizzing. Yeah, you've been bringing out very valid points, but does she know what is icodextrin?
Okay. So it is a basically polyglucose molecule with in which the glucose molecules are linked with 20. It is derived from a Greek word ikos, which means 20. So the 20 molecules are joined together.
So what is the advantage of using an icodextrin?
So it is not, it is reabsorbed very slowly into the body, and that is through the lymphatics. There is no diffusion for the icodextrin like it is for the glucose. So the UF can occur for a longer time.
So it is very good for increasing the ultrafiltration. Yes. Now, how will you make out your peritoneal membrane is failing?
If the patient, the UF is also decreasing, and the solute transport, which we can see with the nutritional parameters and the blood parameters, if they are deranging, they are also deranging, then we can consider that the peritoneal membrane is failing.
So what are the features which lead to peritoneal membrane failure?
So one
What all
is the,
conditions?
sorry, sir.
What conditions lead to an early membrane failure?
So one is the repeated episodes of peritonitis that can cause, and then the kind of fluid we are using. It is more with the uh, higher higher concentration glucose solutions over the lower concentration, and then the pH of the fluid, the low pH
Okay.
fluids with more number of GDPs will lead to early failure.
Now you have been inserting CAPD catheters percutaneously, isn't it?
Yes, I have
So
done.
what is the site of puncture?
So we can do in the midline below the usually we do below the umbilicus, but it depends upon the belt line of the patient. In the obese, we can with the higher belt line, we can usually go for a sorry, in the obese with the lower belt line, we can put the incision can be given above, and in others we usually go for a incision around 2 centimeter below the umbilicus. Some usually the lateral around 1 to 2 centimeter lateral to the midline.
No. Tell me why do we go in the midline? What is running laterally along the rectus sheath? What two arteries are running which you want to
One
avoid?
is inferior epigastric artery. We want to avoid basically.
So either you go lateral to the lateral rectus border or you go in the midline. So you have to be very careful. If you injure the arteries which are running along the lateral border of the rectus, you cannot even hold the artery. They will just vanish inside and they will bleed. So you have to be very careful about the artery when you puncture. Okay, now having punctured, how do you know you're hitting the peritoneal membrane?
So a giveaway sensation we usually feel when we go through the peritoneum, or
Okay, what precautions do you, when is it a contraindication to put in a CAPD catheter percutaneously?
so when there is history of multiple surgeries in the past, or the patient has another abdominal pathologies in the form of any irreducible hernias, or if there are some ileostomy or other fistulas in the abdomen, then it is usually avoided.
Then you do not do it. And once you puncture the peritoneum, what do you do with your catheter?
So when we puncture the peritoneum, then we usually instill the ideally the when we have fluoroscopy, we can inject the dye to look for uh, the pattern the dye is going. If it is going freely and spilling into the abdomen, then we are at the right position. If it is getting collected at the one side, then we may be in the pre-peritoneal position. And if it is going, we can also make out if it is in the bowel, the pattern of the dye. But usually, so if we don't have fluoroscopy, then we can just instill the fluid. If it is going easily, freely, then we consider it is in the abdomen.
So you make an ascites and then you puncture before you start any procedure.
Yes.
How do you know you punctured the bowel?
So the fluid will not go easily, and sometimes it will start leaking from the.
If you puncture the bowel, the fluid will run. It will just run into the intestines.
Okay. So then it may
So
come
how
out
do-
from below.
So when you find that the returning fluid is murky, then you suspect that you have punctured the bowel. And then what do you do under the microscope with that fluid to confirm that you punctured the bowel?
So we
You
look
will
for
look
the
for vegetable cells.
cells.
You stain it with iodine and you look for vegetable cells. Suppose you have punctured the bowel, what will you do?
Like if we have been punctured it with the needle,
Yes.
we can leave it like
No,
that.
you put your catheter into the bowel, then what will you do?
Then do we have immediately surgical
Yeah, don't pull the catheter out.
Yes.
Otherwise, they'll not be able to trace where you have punctured it.
Put the, yes.
So I think that's about enough from my side. If Dr. Vinant has anything else to add.
Yeah. Okay. So I just wanted to ask you, what are different types of peritoneal dialysis catheters that you're aware of, and any comments on which one is superior to which one?
So one is the tank of catheter, which can be a single cuff or double cuff, and then it can be straight or swan neck, and then the tip can be straight or coiled, and then the other catheters are also available. The one is double disc catheter. Then one is the with the tungsten filament at the bottom, which usually prevents the, which is heavy, so it prevents the catheter migration. And one is the disc bead, which is Missouri catheter. So it will keep the catheter in position, and the double disc is to keep the bowel away. And among the swan neck and the straight catheters, usually they say there is not much difference, but the swan neck is preferred if the belt line is, if we are keeping the exit side downwards, and if we are keeping the exit side straight, then usually the straight catheter is preferred, and outflow problems are less with the swan neck catheter. Then in the coiled and the straight tip, in the coiled, the patient usually complains of less pain due to the dispersion of the fluid. Although, so this is plus minus, there are no clear cut benefits of
Right.
one or the other.
So can you tell me the parts of a Tenkov catheter?
So, okay.
And also, can you also tell me the parts of the entire, can you describe the entire apparatus of this peritoneal dialysis catheter along with the attachments?
So one is the, we have the, in the tank of catheter, so there are the distal, the intra-abdominal part is there with the side holes. Then there
That's
are
called
two
the body of the catheter.
sorry,
That's
sir?
called the body of the catheter.
Body of the catheter.
Okay, then what else?
Then is the subcutaneous part between the two cuffs. It has that are made of dacron cuffs, and so then the catheter is attached to the titanium adapter, and over that the transfer set is attached, and over along then to the transfer set we usually connect the Y shape, like inflow and the outflow drains.
Okay.
And
so if you have to view the Tenkov catheter under radiography, what is the most important thing in a Tenkov catheter which permits you to view it even with a radiograph?
so there is
Plain
a
radiograph.
white line which we can see under
Yeah, so
the
what is
flow.
that white line called? So that's a radio opaque barium impregnated substance which travels all the way down to the tip of the catheter, with which you can see whether there's a bowel wrapping, whether it's migrated up, whether it's in the pelvis or something like that. So, and who was the first one who actually described peritoneal dialysis?
Peritoneal dialysis. Okay, Gardner, something. I don't know, sir. Something from G.
Yeah, it's George Wegner. So he
George.
did it for the first time in rabbits, where he demonstrated the hyperosmolar and hypoosmolar fluids could actually be used to make solutes move across a membrane. And the Tenkov catheter that you use, was it just the Tenkov catheter, or was it somebody else along with Tenkov who designed the catheter?
Catheter, Tenkov and catheter.
Yeah, so was it somebody else also, or just Tenkov who designed the entire catheter?
No, sir, there was one person. The name is Keket.
Schechter. Yeah, so who was Schechter and who was Tenkov? So one of them has to be a radiologist and one of them has to be a surgeon. Who's who?
Tankov is a surgeon, sir. The other one is radiologist.
Yeah, so it's important in life to be the one who's on the patient, because then your name is there forever. So nobody knows Schechter. Schechter is the one who impregnated the catheters with barium. He's the one who explained how to place the catheter in the peritoneal cavity. And Stenkov, who is the catheter is named after Tenkov. So I think it's time.
Yeah, I think we can wind up unless they have some questions. Then I'll just sum it up what you have described. If the participants have anything to ask. Okay, if there are no questions, I think we'll sum up and I'll just highlight what we discussed today. We discussed the importance of residual renal function and how it is important in PD. We discussed the PET test and how it's important to know what sort of a transporter your patient is into deciding what form of dialysis you would like to do. We discussed about peritoneal dialysis infections and what should be the initial management in PD infections. We spoke about mechanical failures in the catheter when there is no flow and how you should do. Then Dr. Vinant brought out very clearly on the adequacy of peritoneal dialysis, how you calculate KT by V and how it is expressed and why it is important. Then we spoke about adequacy of dialysis clinically in our patients. And I think very importantly, we spoke about in the clinical examination of your patient, you should know what you are looking for. Thank you very much for your presentation. Anything, Vinant?
No, thank you. Thank you very much. I think it was well presented. And thank you, sir, for giving all these points to us.
Okay, then bye-bye and all the best.
Thank you, sir.
Good night.
Bye.
Good night, sir. Good night.
Thank you.
Asta, end the meeting. Asta, you can end the meeting. हेलो हाँ मीटिंग खत्म हो गई यार हाँ 2 मिनट हो गए आप खत्म कर दो एंड कर दो ना क्योंकि वो लोग कोई लोग वहीं रहते हैं ना कुछ लोग क्या करते हैं ज्वाइन तो कर लेते हैं बाद में वो घूमते रहते हैं ना